Okay, hi everybody. Welcome to our second session. Wow, time flies, guys. And today's St. Patrick's Day. So happy St. Patrick's Day. Hope you guys are going to party on the weekend, have a good time. Some of you may be enjoying a bit of March break this week. So hope you guys are having fun with your families and having a little time off. We will be starting in a second or so while everyone is connecting. Please share your profession and where you're tuning in from in the chat. Whether you are a student, a professor, a health promoter, all of the above, everyone is welcome. With that, we are so thrilled to have you join us for Health Promotion Ontario's 2022 webinar series, Resilience, Recovery, and Renewal in Health Promotion. Today, like I said, it is our second session of our series, and we will be focusing on the theme of misinformation and miscommunication. I'm Gaia, a member of HPO's Professional Development Subcommittee and the moderator for today's session. We'd like to start today's webinar by acknowledging the traditional lands on which we're situated. Today, I'm meeting virtually with you from what we now call the Greater Toronto Area, or the GTA. I acknowledge that this is the traditional land of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wenda peoples, and is now home to many diverse Inuit, First Nations, Inuit, and Métis peoples. With this, I respect the longstanding relationships that Indigenous peoples have to this land, as they are the original caretakers. I acknowledge historical and ongoing injustices that Indigenous peoples endure in Canada. I encourage you to take time to reflect on the traditional land on which you're situated and how you can play a role in renewing respectful relationships with Indigenous communities. Now, today's session is made possible by our Professional Development Subcommittee, the Ontario Public Health Association, and of course, Health Promotion Ontario itself. As the voice of health promotion across the province, HPO seeks to advance the importance of health promotion through professional development, member communication, and advocacy. Consider becoming a member today. First, a few housekeeping items. Please do note that this session is being recorded. We can see the little recording button at the top left of your screen, and it will be available on the HPO website later this month for your convenience. We also encourage you to share your questions in the Q&A. Don't be shy. Put them in and participate in discussions using the chat box during the presentations. We love, love, love to see interactions. Okay, so who's ready to get the party started? Our first speaker is a member of university research teams addressing digital media in agriculture, rural community resilience, and climate smart soils. Please help me welcome Professor Dr. Helen Hambley from the University of Guelph.
Hello and welcome to the session, Building the Backbone of Digital Equity in Ontario, Why Digital Divides Matter for Health Equity. My name is Professor Helen Hambley. I'm the project leader of Regional and Rural Broadband, R2B2, based at the University of Guelph. R2B2 is Canada's largest and oldest research project on rural connectivity. We work with all levels of government, internet service providers, not-for-profit organizations, and scientists from a range of disciplines. We also have a strong focus on geospatial and economic analysis in our work. And we delve into specific thematic areas such as the need for internet in agriculture and digital equity for health and education. Let me begin by explaining that here in Canada, internet access is defined using a speed threshold. It's known as the basic service objective of 50-10 megabits per second. That means 50 megabits per second download and 10 megabits per second upload with unlimited data at a residential or household premise. In theory, 50-10 is deemed sufficient for basic data throughput, like streaming some video, although there could be some delays or buffering. But 50-10 megabits per second is increasingly insufficient when the number of connected devices at the premise or the number of users at the premise increases. Is internet access a problem in Canada? Well, on face value, national statistics don't look too bad. About 94% of Canadians have access to the internet at home. But what if you don't have a residential dwelling? Or what if you're an individual with a precarious situation at home? We can see some clues into digital equity when we look further into StatsCan data. 80.9% of Canadians in the lowest income quartile have home internet, compared to almost 100% in the highest income quartile. So income matters. Secondly, connectivity is not the same for all Canadians. Network access involves different types of connections that affect the quality of service at the national threshold of 50-10 megabits per second. Connectivity varies by the type of connection available, therefore. And we can see that in this view of Canada and its internet service availability. You can see that northern and remote communities are often satellite at home. The lowest income quartile have home internet compared to almost 100% in the highest income quartile. So income matters. Secondly, connectivity is not the same for all Canadians. Network access involves different types of connections that affect the quality of service at the national threshold of 50-10 megabits per second. Connectivity varies by the type of connection available, therefore. And we can see that in this view of Canada and its internet service availability. You can see that northern and remote communities are often satellite dependent, and these types of technologies, these earlier generation of technologies, experience a lot of issues around quality of service, well below the 50-10 megabits per second threshold. The gray areas represent communities that are still struggling to get 50-10 megabits per second. They're typically rural. And then, of course, we have our urban environments where there's 50-10 megabits per second available, and often upwards of 1 gigabit per second service levels available. So there is a major evidence of a digital divide across Canada. Let's zoom into Ontario. Well, the data collected by the R2B2 project shows that about 12% of Ontario residents live in communities with insufficient or no connectivity. 9% of our roads are not covered by the latest mobile technology. 30% of rural households must rely on more costly mobile wireless services. And overall, approximately 700,000 residential and business premises are routinely at or below basic service of 50-10 megabits per second. You can read more about this research in our policy briefs on the R2B2 website. So digital divides in Canada are highly relevant to healthcare and services. Why do we say that? We can see this in the overlay of the data for digital equity and the digital for health equity. Who can typically access basic internet services at 50-10 megabits per second? As I said, it's primarily urban areas. About 99% of Canada's urban areas are served at that speed threshold level, compared to only 46% of rural areas and 35% of First Nation reserves. Health equity, on the other hand, is also an issue in urban areas, but more so in rural areas. Approximately 1/5 of Canadians live in rural communities, and these communities are served by only 8% of the practicing physicians in Canada and only 2% of health specialists. What we're seeing in today's world is that health equity is increasingly influenced by digital equity and vice versa, primarily because of the importance of telemedicine and telehealth applications. So health promoters and the wider health sector have been leading action plans for internet access and digital equity for everyone in Ontario because of the close association with health equity. Digital equity actually has 3 dimensions: network access, which is the internet available where you live, and what are the types of connections that you have, and the speeds and the quality of service in that network access. Secondly, access to connected devices. Do I have the tablets or the cell phones and the laptops with secure software and also other applications relevant to my users' needs? And then thirdly, is there digital literacy at the user level? These are capabilities that not only influence the exchange or the knowledge of the information being transferred digitally, but also other capabilities around managing risks, identifying misinformation, addressing hesitancy about privacy and the security of one's data. So these 3 dimensions, network access, access to connected devices, and digital literacy, all work hand in hand to influence the usefulness of internet access at the user level. But all of these are in fact influenced by whether or not you live in a rural, urban, northern, or Indigenous community, because of the influences of location on network access and possibly on connected devices and possibly on digital literacy opportunities, but also your individual and household income, two distinctly different things. So Ontario needs a strong backbone for internet access. Just like human beings, we have a backbone in our internet systems, and there are gaps and weaknesses in that backbone. There's issues to address around equity, and as I mentioned, around the actual access to devices and digital literacy that make access to the network useful. There are, of course, historic infrastructure investments. Ontario has pledged almost $4.8 billion in recent years to filling the gaps in our internet backbone. We have a COVID-19 action plan for people-focused government that expressly states that broadband and the investments being made in that infrastructure are essential to managing through COVID-19 and beyond it. We also have an action plan for broadband and cellular that is shaping and influencing the build out and construction of more infrastructure. This is primarily being done through a reverse auction known as OSEP. And just recently, there has been an announcement to accelerate the project build outs. We have funding from the federal level as well. The federal level has already approved approximately $52 million worth of investments in Ontario, covering 33,000 or so households. So all of these historic infrastructure investments are changing and improving the internet backbone. But when we look at internet access in relation to digital equity, we see that it's really slow to improve. It's a bit more like having to seek physiotherapy for our back pain. These are complex projects that have a lot of recent disruptions. It's almost like having an accident, again, after having a back injury. This is what happened with COVID-19 in Canada, and the circumstances were really sometimes outside of our control. For example, the impact on disruptions in telecommunication supply chains. Another aspect of the backbone that needs monitoring and improvement is the fact that technologies are changing. 5G is emerging in the landscape, and we need a review of our existing institutions, those rules of the game like spectrum policy and spectrum auctions in Canada, to find out whether or not the licensing and the rules will favor those who are least likely to currently have access to high-speed internet. As well, we need an evidence base to inform policy and the goal of universal internet connectivity. This includes achieving affordability and digital literacy that really does influence misinformation and malicious or malinformation. Many communities are taking a stand. They're using their own backbone to stand up and take action around digital equity and health equity issues. I'll just flag a couple of them that I'm involved with here in this slide. Here in Guelph, Wellington County, there is a task force focused on digital equity. They've issued a call to action to close the digital divide in Guelph, Wellington. They're formulating a number of initiatives that range from free or loaned devices, upcycling of donated hardware, as well as problem-solving software, and building digital literacy training and trainers of trainers in digital literacy. They're also facilitating exchange of information about low-cost plans from providers or offering free or subsidized internet subscriptions to needy users. There's development of municipal Wi-Fi hotspots across Guelph and Wellington, and this is particularly important in rural areas where often Wi-Fi hotspots are missing. And there are partnerships as well for monitoring and evaluating the outcomes of these digital equity activities, engaging the widest range of key partners possible. In Hamilton, during the pandemic, a major study was conducted in partnership with the R2B2 project. City of Hamilton has now started to use this data to inform its digital equity strategy. On the right of this slide, there's a graph that says something quite important and interesting for us to follow up with further research. Here we see again this relationship between the lowest income groups, less than $30,000 a year, spending a very high share of their income on broadband services, 7%, compared to the highest income quartiles, where it's less than even 0.5% or around the 1% mark. This is a flag to digital equity within the city of Hamilton. And as the city goes forward, formulating strategies to address the needs of lower income households is going to be absolutely essential. Let's recap on some of the key points that we talked about today. First of all, I hope you've grasped the scope of the backbone problem. We have an aching backbone where the internet is concerned in Canada that needs a lot of attention and strengthening. This is going to be done by engaging with public policy making and directing key investments to mend the backbone and keep it healthy and strengthen it, almost like physiotherapy, with more messaging, more initiatives around digital equity. And why is this important to health equity and health promotion? Well, frankly, the health sector is central to achieving digital equity. The health sector and health promoters will be using digital technologies long past the COVID-19 era, and also struggling to address complex issues like malinformation and misinformation that are, of course, quite relevant to the evolving digital technologies and applications running on that infrastructure. And then finally, I think there's no doubt that local action and achieving outcomes where digital equity and health equity are concerned is of utmost importance. A lot of the action has to happen locally, not just in partnership with federal and provincial partners. And that local action is where we can come in. We can share and exchange our knowledge. We can look at evidence and data issues that we might be facing, and we can build partnerships forward to support digital equity and health equity in Ontario. Thank you very much for the opportunity to present to you today. I'd like to thank Health Promotion Ontario and acknowledge my team at the Regional and Rural Broadband Project at the University of Guelph. Please contact us if we can be of further assistance. Thank you.
Thank you, Dr. Hambley. It is so eye-opening how much digital equity can affect our lives. So everyone, if you have any questions regarding the presentation, feel free to put them in the Q&A portion of the webinar for the panel discussion coming up. Now, following the flow of academia, I would like to welcome our next speaker, a PhD candidate in public health, also from the University of Guelph, whose work focuses on the practical application of communications and knowledge mobilization across multiple sectors, including public health and research innovation. Melissa McKay, take it away.
During a time of crisis and uncertainty, the greatest asset we have in public health is trust. Trust impacts the speed at which we are moving through a crisis, and communication is really a fundamental influence of that trust. Trust in government, politicians, public health, and healthcare have all declined over the pandemic, in part due to inconsistent and ineffective communication. My name is Melissa McKay. I'm a PhD candidate in public health at the University of Guelph, and together with my advisor, Dr. Papadopoulos, we're working on understanding how to demonstrate trustworthiness through effective crisis communication during emerging infectious diseases, with a focus on applying this knowledge to social media. So a little background about the project that I'm speaking about today. We received a SSHRC Partnership Engage grant in the September 2020 competition, ultimately to develop a guidebook for public health to be able to apply evidence and best practices for effective social media crisis communication during emerging infectious diseases. And this project consisted of a scoping review where we mapped the literature around effective crisis communication on social media during emerging infectious diseases, as well as conducted an analysis of a bunch of influencers on Instagram to look at how effective their crisis communication was and how the public was responding to it. So the guidebook combines that evidence along with some research that we did on Twitter and Facebook as well to help public health really understand how to apply this theory, evidence, and best practices in this area. So during this webinar, I'm going to go over some of the key points from the guidebook so that you can apply it to your crisis communication on social media. So communicating in a crisis is different than other types of health communication. High levels of uncertainty result from new and unfamiliar risks, such as emerging infectious diseases like COVID-19. So during a crisis, people take in information differently, they're processing it differently, and they're even acting on it differently. And some of this does relate to fear and the fact that that impacts people's ability to really process complex information. And within this kind of information landscape, we're being exposed to a huge amount of information in a really interconnected way. So, some of it's factual, but some of it is false or deliberately misleading. And our ability as public health to cut through this complexity relies on the trust that we have with individuals and our ability to effectively communicate. So there's this assumption that, skepticism towards science or public health is a result of a lack of information, and that if we can just provide more information to the public, they're going to follow our advice. And as I previously talked about, there's this huge abundance of information, especially around COVID-19, available to the public at all times at their fingertips from a huge number of speakers. So the issue really is that, people are questioning the trustworthiness of science and of public health, of government and others, not because we're not providing enough information, but because we're not applying effective, crisis communication principles to our messages. So we really need to demonstrate our competence and the willingness to act in the best interest of the public through detailed, honest, and balanced communication. Effective communication during a crisis can save lives, and trust is, really one of the most important outcomes of this effective communication because it's influencing risk perception and it's impacting whether people are going to adopt risk protective measures. We're competing against media, celebrities, influencers, conspiracy theorists, and others, especially online, for attention. So we need a really creative, coordinated, and transparent approach to our communication to better meet the needs of community members. And partnerships between public health and other trusted organizations can really boost the credibility of public health and, help our messages have more organic reach in social media. Physicians, celebrities, brand influencers, media personalities, and politicians that are viewed favorably by a community have really been found to have positive impacts on risk perception, on people sharing messages within their social networks, and if people engaged in risk protective behaviors during COVID-19. So our audiences are judging our crisis messages based on the content we're providing, who the messenger is, and the communication channel that we choose. So it's really essential that we understand information preferences, including what channels our audiences prefer, to be able to increase the reach of our messages and the impact. So in public health, we're often using demographics, but audience segmentation also includes other things. So we're dividing our audiences based on similarities, including behaviors, whether they engage in a behavior or not, what their needs are, their opinions, their values, and their, the social determinants of health. So we're, supporting the development of crisis messages more suited to various subpopulations' needs, which is more likely to result in the behavior change that we're seeking. So working together with subpopulations to kind of co-create messages is really a best practice of effective crisis communication. And the one-way push model where, we're providing a one-size-fits-all model across all communication channel doesn't really meet the needs of all members of our community. So involving groups wherever possible in that kind of communication process should be worked towards, if possible, to provide more nuanced communication and more relevant information. The guiding principles of effective crisis communication that contribute to public trust include clarity, compassion and empathy, correction of misinformation, timeliness, and transparency. So transparency is probably the most important guiding principle. It involves sharing both what's known, but also really importantly, what isn't known and how we're going to go about finding that information out. So it's giving really detailed information about how decisions are made, and it's priming our communities to really understand that science evolves, we want that, and that recommendations may change with new information. Compassion and empathy is showing the public that we care, that we understand there's challenges associated with, the emerging infectious disease and some of the measures we're putting in place, and that we're working towards helping them overcome these challenges. Clarity really ensures the appropriate language for various subpopulations, and that you're targeting and tailoring information and channels and messengers. Timeliness means that you're releasing information as soon as decisions are made or as soon as new science becomes available. And finally, correcting misinformation is just what it sounds like. It's addressing rumors, it's addressing myths, and it's addressing conspiracy theories out there. So these guiding principles are all interrelated. They're likely functioning together to increase our message acceptance and, importantly, the uptake of public health behaviors or recommended behaviors. So while not every message is going to include all these, or the content isn't relevant for all these principles, some are really critical and should be used consistently, like clarity and like transparency. So crisis messages should also include information about the threat, which is the combination of severity information and susceptibility information regarding the emerging infectious disease. So severity is information about the health and social consequences associated with the disease, and susceptibility information is information that shows that people are vulnerable within a community. So it could be like numbers of deaths, numbers of cases, variants spreading within a community, that sort of information. But we also need to provide, encouragement, and that is in the form of either cues to action or efficacy information, which are really prompts for individuals to engage in a behavior, and information that makes them feel like they know what to do and they know how to do that behavior. So really importantly, when crisis messages demonstrate high threat and high efficacy and action together, we know that they're much more likely to engage in the protective behaviors that we're recommending. Whereas if one, threat is low or efficacy and action are low, or both of them are low together within crisis messages, what happens is that people respond defensively, they just shut down, and they reject the message altogether. So vivid language, pictures, and individualist language about how, the infectious disease can impact that person and the people they love are really good at increasing perception of risk or threat within an individual. And our research also found that when threat was used in combination with cues to action and efficacy, we had higher positive emotional response to those messages. So as you know, social media platforms have functions that allow us to kind of better understand the needs of our subpopulations, how people are responding to crisis messages, and the reach of our messages. So it's important that we're targeting our platforms and then sort of understanding how our messaging is landing. So you can do some of this targeting through using more conversational tone, including images and videos that are really targeted and also display that kind of threat and cues to action information, and taking accounts that have more reach and more trust built within the population you're interested in reaching. But also there's a couple tools that are really interesting. One is called sentiment analysis, and this is just a tool that can tell you the emotional response people are having within the comments of your social media posts. So as you're monitoring sentiment, it's going to tell you if people are feeling more positive or more negative. And, important to note that negative comments on social media have been shown to sort of persuade others to also view those crisis messages in a negative light. And then engagement metrics such as, number of likes, number of shares, number of retweets, number of comments, overall show you how actively involved people are with your content. And importantly, people are using that information about engagement to evaluate the content they're seeing. So, that information about engagement is influencing individuals' attitudes towards not only the information, but the source as well. So understanding and incorporating aspects of crisis messages that you are seeing increase positive comments and increase engagement is a really important aspect of also being effective with your crisis communication on social media. And you can use platforms like Hootsuite or Buffer to do sentiment and engagement analysis, as well as there's some tools within the platforms themselves. So to summarize, this 4-step approach is allowing you to draft crisis messages that are audience focused, they're evidence-based, and they're providing sort of feedback back into the process where you can understand how to increase that positive emotional response and that kind of organic spread and reach of messages. And while a highly segmented approach, might be difficult, you can layer your approach where messages intended for general public are layered or used in combination with a more segmented approach for different audiences. So I just want to acknowledge the participants within our SSHRC grant. We had a great team from the University of Guelph, and we also are partners with the Canadian Public Health Association and the National Collaborating Centre for Methods and Tools. And the other acknowledgement I wanted to make is that we do acknowledge the fact that public health exists within a governmental context where social media use can be challenging. So we recognize that there's resource restrictions and that there's restrictions based on approvals. And so this guidebook is really, and this webinar is really meant to help you understand what the evidence is saying, what are some of the best practices, and then you can fit it within your own context and constraints to hopefully increase the effectiveness of your crisis communication on social media. So thanks so much for your attention, and just wanted to also note that we will be releasing the full guidebook in the coming month or so, and we'll circulate it through this network as well as through CPHA and the National Collaborating Center for Methods and Tools. So please feel free to reach out to me. I'd love to hear from you. Thank you.
That was fantastic. Thank you, Melissa. The guidebook will definitely serve as an excellent tool to dissect into this challenge further. I would like to remind our lovely listeners to continue posting your questions in the Q&A section. Keep them coming. The panel discussion is right around the corner. Next, we have a dynamic duo from the Ottawa Public Health. Joining the social media team in 2020, Amanda Higginson, a project officer, specializes in youth and young adult content at Instagram. Presenting with her is Kevin Parent, the program and project management officer. He's the mastermind behind Ottawa Public Health's successful Bruce campaign that went viral. He even got a write-up at Maclean's. All right, the stage is yours.
Hi, my name is Amanda Higginson, and I'm here with Kevin Parent, and today we'll be talking about our social media strategy countering misinformation throughout the pandemic. Ottawa Public Health has Facebook, Twitter, and Instagram, as well as TikTok, and so we've been operating on those social media platforms for quite some time, but throughout the pandemic have had a lot of interactions and experiences in countering misinformation, and yeah, we're here to talk to you about those today. So I'll just jump right in. Sometimes people on Twitter lie, and if you spent any time on the internet in the past 2 years, I'm sure many of you have had an experience or of some sort with misinformation. It's quite prevalent, and unfortunately more so with COVID-19 in the health community. So there are a couple of strategies that our social media team has used to kind of tackle misinformation, and most of them root back into the idea that misinformation is in fact a public health issue. And so we treat it like one in the way that we treat a lot of our other public health topics, in sort of trying to make it engaging and interesting and something that people can talk about, as well as countering it as best we can and trying to prevent it, and when we can't, addressing it directly. So one of the ways that we are able to counter misinformation is by using prevention. We find that oftentimes misinformation breeds more strongly when there is a lack of information available to the public. When people don't know or don't have answers, they come up with their own. And that is a huge issue for sharing misinformation, because you just want to share what you think is best. And sometimes that information doesn't exist in an easily digestible way. And so we've been using Twitter threads throughout the pandemic. This was our very first thread, which was posted on July 3rd of 2020, and it was related to mandatory masks. And the idea behind these threads is to add additional context and background information to complex health topics that are really hard to digest and understand, and to give people a longer form, engageable and easily digestible answer to a lot of the questions that pop up when we have new guidelines come in or when new research comes out related to COVID-19. Kevin likes to refer to these threads as sort of a coffee chat with a friend kind of moment between our social media folks and Ottawa Public Health and with our followers. And it's really a moment to sort of sit back and take a minute and talk about maybe the experience that we've all been having, or some of the information that's come forward in a way that breaks everything down and is really easy to understand and gives people a chance to sort of digest it without having to feel like this is all new information and there's not enough of it to, go around, or there's no answers available. And so this is where the idea of threads have come up. Since this thread, we've used this tool quite frequently. It's been really, really helpful in our communications, not only in countering misinformation, but in having that moment with the public to really connect. And since then, we've posted 24 threads. So it's something that we've been able to do a lot of, thankfully. But having this additional information when things change makes it a little bit easier, because there's a place where people can go to read up more if they're interested and have something to point back to when they're sharing information. And it makes sure that people are able to share something that has been given out in a timely manner and that is reliable and accurate and that they can trust from a public health source. So having these threads has been helpful in having an informed population for sure. The other strategy that we use to counter misinformation is to address and correct it whenever we see it. So is a post that we put out about 6 months ago, and it was countering some misinformation that we had seen popping up in the population about the passing of a child from an adverse effect after a COVID-19 vaccine. So we'd seen this misinformation being spread early in the morning on December 6th, and we, had flagged it up and were able to come back to our partner organizations and check our own records and confirm that it actually was not true. And so we posted this around noon that day, and it was a really timely and quick response, and it corrected the information and addressed it directly. So those two aspects of this post really resonated well with our followers. It did quite well, and it was appreciated by so many people because at the time, parents had quite a few concerns about the vaccine, of course, understandably, and having this story spread about a child who had passed was very concerning. And so by addressing the root of the issue and by talking directly about what we had been seeing online and correcting it, we were able to help a lot of people to sort of make a more informed choice about their vaccination of their children, and as well to, get information out there about how quickly misinformation spreads and raise awareness about how easy it is to see a story and click share and maybe not have all the facts, or maybe having done it, you didn't realize, but it couldn't, not necessarily is true. So we do that as well. And finally, we like to treat, as I had mentioned earlier, misinformation as a public health issue. And so we like to have fun with it and create engaging content that just raises awareness, that makes it interesting for people, and that makes people have a conversation about misinformation as its own thing. So this was a post that Kevin had written just about the idea that COVID-19 is a global conspiracy involving every nurse, doctor, hospital worker, health unit, and government on Earth. Shows a rather optimistic view towards project management. So resonated really well with our Ottawa government town, for sure. But we also were able to link back to our website, and on our website we have information about misinformation and how to avoid it and how to identify it online. And so we have fun engaging with misinformation as a public health topic and making it interesting for people. We also did this Star Trek related post not too long ago as well, and it got quite a good response. With talking about misinformation online, of course, it's not always rainbows and sunshine. We do get quite a few people who are upset with us. And so we have been able to counter that and have a conversation around that as well in some a more cheeky way. But of course, it's important to think about our mental health and how we're doing as a social media team in relation to all this. And if you spend any amount of time online, seeing misinformation or not, it's sometimes a very difficult place to be. So I'll hand it over to Kevin to talk a little bit about the mental health side of the work that we do.
Thank you, Amanda. Appreciate that. And I mean, as you can all tell from my hairline, I have no business making, youth focused content. I actually had to explain the Star Trek joke to everyone I worked with. But yes, it's been a very interesting couple of years to say the least. And as Amanda said, there's a pretty dark side to doing, health communications during a pandemic, and it can be very, very difficult. You always have to be mindful as a communicator of the effect that this is going to have on yourself. I mean, I'll be quite candid. I actually just myself came back from an extended leave. I've been in the therapy and just trying to, rebuild myself in terms of, the damage that I did to my own mental health of doing this for 2 years. So, really, really be mindful of what you're going through. And this tweet is probably one of my favorite things we've ever written. It's actually still pinned to our Twitter profile over a year later, and it really speaks to the environment that we all exist in. Of just take care of yourself and do the best you can, and you'll be fine. We wanted to really end this one on a bit of a brighter note, especially after being a little somber. So we decided we'd give you the insider scoop. The question that everybody always wants to know of where the heck did Bruce come from? You'll be happy to know that as a government organization, Bruce came from the most boring place ever. We needed to do some communications about the Super Bowl, and we accepted the fact that we're not exactly super fun and interesting and exciting, so we approached it from that angle. This post that went out, fun fact, the entire thing was just a vehicle for the second part of that post. Talk to any crisis communications theorist, they'll talk to you about the importance of being empathetic and understanding of the things you're asking the public to do. And when you think of Super Bowl culture, you think of like big wild parties and everybody together and 40 guys crammed into a room. It actually is like a public health nightmare, by the way, like everybody sharing finger foods and all that. Not great. So we asked everybody to do it virtually. That was a really big ask. So we needed a way for this post to get out and be shared widely. And the way we went about it was giving it that hook, that Bruce, make sure to, do your thing. The whole thing was a bait to just get people to reply and say, you had one job, Bruce. Therefore, we could start mixing it up with the replies. I mean, the next one is one of my favorite interactions that happened on all of it. Somebody replied and said, Bruce is either in deep, or Ottawa Public Health is about to follow this up with, now that we have you all here, wear a mask and stay away from people. So we genuinely, at 11:10 p.m., copy-pasted his message and threw it right back at him. And as you can see, it blew up, because that was the first real clue that, by the way, this was actually a gaffe. But what we noticed, and where misinformation comes in, is by the next morning, there were actually people that had taken it seriously. There were a couple of stories that were written, and there were people talking about, how this tweet demonstrated the ineptitude of public health, and we couldn't even do social media properly. So we did a really quick pivot on the Monday morning and rolled with it. You see, that tweet blew up more than we ever thought it could. There was a data analytics firm that said that of all the interactions with the Super Bowl hashtag on that Sunday evening, it was the 7th most interacted with tweet globally, including all the posts from the teams, the players, the leagues, everybody. It was the 7th most interacted with Super Bowl tweet around the world. So we wanted to kind of then grab the misinformation that came out of it. So we wrote a 4-part thread, and we walked people through little clues, little tidbits, like, the image that you saw in the tweet that has put the team logo here. Why would we do that? It means that somebody would have to go Photoshop that out at 11 o'clock at night. It makes no sense. And the fact that we were online and engaging. So it's not like we scheduled it and forgot about it. We were online. If it was wrong, we would have fixed it. And we walked through a couple of other examples. And the reaction from the public was just wonderful, and people really enjoyed it. But this we always have to include, because the one person that really just took it to the next level on taking care of Bruce, was a wonderful interaction. And one of the best things about these things is, as we mentioned before, it's a very difficult time out there, and when you can provide health information in a way that also gives people these moments of levity, little bit of something to take their mind off of what's going on, it's just that little bit of an added bonus. And the story of Bruce didn't actually end there, but our video will, due to the limits of internet buffering when you are a taxpayer-funded organization. We have a video of where the story of Bruce eventually went, which culminated in something that we still, to this day, cannot believe. And we're going to play it at the end of this, because every time we tried to play it for you, it got very slow and choppy. And Amanda got really mad at me when I said that we should just roll with it because she's very aggressive. But thank you. Appreciate it, everybody, and we're really looking forward to having a conversation with you and answering all of your questions.
Thank you, Amanda and Kevin, for your informative presentation and for sharing some of the tweets. Looks like we also may know the secret identity of Bruce, and just saying Ryan Reynolds, just saying, you know, secret agent. It is time, though, we open up the floor for some of our questions. Thank you, everybody, for sending in your inquiries. Please do continue your submissions for our last presenters. We will be circling back to you. Now, Helen, Dr. Helen Hambley, are you ready? I'm going to hit you with a question. So it states, is there a role for training of providers or organizations to help prevent or mitigate digital inequity as it relates to health while we wait for the backbone to be strengthened?
Yeah, the easy answer is absolutely, and it's already happening. So one of the things that I'd like to encourage all of you to do is just share experiences and how the health promoters can actually get involved in working on digital equity issues within what they're already doing. So the argument I would make is that you're already working on health equity. To do an overlay with digital equity would be fairly straightforward. The backbone, the internet backbone and accessibility to everyone in Canada, of course, is still being built, and it's going to have to be strengthened for many years and decades to come from everything we know about it. But at the same time, it doesn't mean we don't do anything at all. We must ensure digital equity right now from the outset, and that means ensuring that the public that you work with are aware of digital equity issues, that if they are seeking resources, there's resources available within communities, but also sort of the options of getting organizations who are involved in health equity behind the digital divide question. So yeah, I think that it's absolutely possible.
Thank you. Sorry, I was trying to find, Zoom can be tricky sometimes. Like, where's my video? Okay, excellent. Now, moving on to Melissa, we have one of our participants, Brooke. She's wondering, when presented with this information, some people simply deny that there are impacts on themselves or the people around them. Has your research examined what works for this group to get valid information across? If so, what are some strategies for communicating with them?
It's a great question, and it's challenging for sure. So I guess the research that I've come across in this is through some scoping reviews and a systematic review. And that's really where that audience segmentation stuff comes in. So I think it's really important that we are speaking directly to people's values, their identity, their behaviors, etc. And then also influencing risk perception is another really important thing. So if we're not meeting people's needs in terms of helping them understand what their risk is and helping them understand like how to engage in the behavior, they're going to shut down and deny that it's applicable to them. So the other thing that I've seen in the research as well is that it's that collective responsibility versus individualistic kind of messaging is important. And that individualistic messaging is resonating, especially with people that are vaccine hesitant. So where the messaging is more direct to this can have an impact on you and the people around you that you love. There's an interesting program out of Australia, I think, called I Immunize that was, I think, quite successful. And it was really geared towards parents and their identity in being really eco-conscious and like really community focused. And so it was speaking directly to their identity as like parents of young children who like might use cloth diapers and might not drive a car, but that they immunize, kind of thing. So anyway, there's a lot in there because it's really complicated, but I'll stop there. Happy to chat more kind of offline as well.
Absolutely. I believe a few of my colleagues have posted your email in the chat, so people feel free to connect with our speakers afterwards for an offline chat. Now let's move on to our next topic for Amanda and Kevin. So one of the questions reads, what is the role of diversity and voices from the marginalized community in health communication? Does disinformation research show that race has been extremely effective in external and Russian disinformation campaigns that contributed to COVID-19 and election misinformation?
Sorry, the joys of looking for unmute buttons. Yeah, I mean, with us, we often say, well, one of my colleagues, she's one of my favorite people ever, obviously other than Amanda, Nikki Hudson. She often says that, you know, on our communications team, we have a communications toolbox and we have to recognize the right tool for the right job. You know, our social media accounts, especially, you know, like Twitter, Facebook, Instagram, they are our broad stroke instruments. They aren't really, you know, our big broad campaigns are more just reaching that mass audience. We have an entire branch of our communications and community engagement team known as community operations. And this is the group that carries out much more targeted communications. They are offline quite a bit. They're doing bus ads, they're doing ads in print news, they're doing ads in different diverse radio stations around Ottawa. They're physically out in the community knocking on doors. They're attending different community association meetings. They do targeted, geo-targeted paid ads on social media with our Facebook accounts and whatnot. So in that sense, yes, you know, there has been a very important role of being able to reach out to diverse populations. In terms of specifically Russian disinformation campaigns and, you know, election misinformation and whatnot, that's really not a space we can go into in terms of the election side. The Russian misinformation has been very strong. There's a network of a few of us social media people from Public Health Units in Ontario that were chatting. And we all kind of noticed that when Twitter got shut down in Russia, a lot of our most popular and vocal troll accounts suddenly went silent for a few days. So it is quite common in terms of the voice and how loud it is out there. But it's also kind of advantageous to us in a way of, you know, we can pick up on the different trends and the commonalities. And as, you know, Melissa pointed out to, you know, the importance of speed, when we actually will read everything all the trolls say. And if we find something common and, you know, a new emerging narrative or whatnot, we'll then immediately start writing content.
Love that. Amanda, would you like to contribute anything?
No, I think Kevin really hit the nail on the head there. I did want to add, I added in the chat though that we've also piloted a WhatsApp program. So kind of branching out of social media strictly and seeing if we can connect directly with diverse communities has really helped, just having that kind of connection, just because social media is such a broad way of communicating. It's really difficult to reach all the populations. And so it's an interesting question for sure. But the misinformation and disinformation bit, Kevin's got that one.
Absolutely, I agree. Kevin really summarized it in a very lovely manner. Okay, well, the next question I would like to address to everybody, whoever feels comfortable addressing this. So it reads, during the pandemic, political figures on all levels of government were delivering public health information. This can politicize public health guidance and messaging. What advice would you have on how best to deliver these messages for future pandemics? Hopefully not, we don't have any, but yeah, so Dr. Hambley, would you like to give it a go? Oh, you're unmuted. Let me help unmute you. Hold on a second. Here you go. You're unmuted now.
Great. It's a great question. It's interesting. I just give an example where during SARS, many of the politicians were pretty quiet. during COVID-19, everybody had something to say. And that's because they realized that, their constituents were asking them questions as well. So many of the MPPs and MPs from our communities had to come up with statements and engage with the issues for a long time. And in some cases, they didn't really always have good public health input into it. So they were sort of ad-libbing or, sending out ad hoc messaging around COVID-19 at some points as well. So I think going forward, like, what are we learning? I guess the question was like, what do we learn for the future? One of the things is that politicians as well as media are really important stakeholders in public health communication. And none of us should be naive about the fact that there's a difference between misinformation when something is sort of sent out erroneously or mistakenly, or maybe without any kind of malevolence or malintent. And then there's mal-communication or malicious communication. It's a completely different thing. And that's where conspiracy theory actually goes to conspiracy action. And if we see politicians moving into mal-communication and malicious information or malinformation, then as citizens, we need to stand up and flag this, because this is clearly not just politicians participating in misinformation. So I think going forward, we're going to have a lot more sort of attention to this distinction. Thanks.
That was a great answer. Melissa, would you like to contribute anything?
Yeah, I'm doing actually interviews with COVID-19 vaccine hesitant individuals. Well, I'm actually analyzing them now. And one of them said, political decisions on health is still a political decision. And it's highly polarized out there. From my research, it showed that, people that present as doctors were most trusted versus politicians are viewed as like making political decisions rather than decisions in the public health. So wherever possible, like having epidemiologists, medical officers of health, those that are presenting as doctors were definitely more highly trusted. So that's not always possible though, like Helen's saying, because of the communication landscape. Yeah, I'm gonna leave it at that though.
I agree. And honestly, I know that some doctors are now, internet famous. Some of you may have heard of Dr. Mike on YouTube or on Instagram. He's an advocate of, sharing the right information. So I definitely agree that when you see a doctor presenting that, it is more trustworthy. So the last question that we'd like to wrap up our session with is, it is for Amanda and Kevin, but Melissa and Dr. Hambley, please feel free to contribute. It reads, it's great to see how approachable you've made your messaging to the public, Ottawa Public Health. Example, like explaining decisions around masking. How can others follow the same approach? I imagine there might be some simple steps to think through when creating messaging. Kevin, would you like me to unmute you? Okay, you got it.
Right? Like, 2 years in, still can't figure this thing out. Yeah, I mean, there's a lot with that. People are always surprised to find out that as much as sometimes we're known for being, humorous and whatnot, everything we're doing is evidence-based. I mean, my goodness, even our cheeky and fun sexual health content is actually based on a whole host of evidence about how effective using humor is, because sexual health is such a heavily stigmatized subject with younger audiences, et cetera, et cetera. Follow evidence. But at the end of the day, our entire social media strategy is just kind of based around this belief of remembering that you're speaking to real individuals. You'll often hear people say, oh, that happened on social media, but this is the real world. Like we truly believe that that's a false notion. Social media isn't a separate world. It's just another medium of communication that we all use. And you'll often see that, like, when we write content, especially those threads, which I adore, we write them as if you were genuinely sitting face to face with somebody and speaking to them in an open, honest way. We don't try to be patronizing. We don't try to, give something a fluff. It's genuinely just a real human to human conversation. Be as engaging as you can. It doesn't matter how good your message is if nobody's paying attention to it. So we read all the comments, we read all the replies, we try to get in and have conversations with people so that they see the account as something that they can be comfortable interacting with. which will then make them more likely to actually listen to what we have to say down the road. I mean, honestly, I could probably talk for an hour on this one question, but I'll stop because I can.
Hey, an idea for a new webinar, you never know. I love the idea of treating them as humans. And honestly, that is a wonderful way to end this session, to keep that in mind. It is 1 o'clock. I'd like to respect everyone's time. So thank you so much to all the speakers for these excellent presentations and thoughtful panel discussions. Thank you to all the participants for joining today and sending in your questions. We hope you enjoyed the second session in our winter webinar series. Your feedback is highly valued. I forgot how to speak, geez. And we would love to hear from you in the post-session evaluation. Feel free to scan it, the QR code, or click on the link after the session. We hope to see you next week for our third and last session of our series on March 24th, which is also a Thursday. Stay connected with Health Promotion Ontario on Facebook, LinkedIn, and Twitter. And don't forget to register to get exclusive member benefits. If you have any questions, don't hesitate to reach out to our team, to our speakers. I love to chat offline. Have a fabulous day, everybody. And once again, happy St. Patty's Day. Thank you so much, everyone. Have a great day. Bye.